Just give them the aspirin guys and get help in to assess them. Okay? The next thing we'll talk about then is a stroke. Okay? Stroke. What causes a stroke, does anyone know? They can have either a clot or a bleed in the brain. Okay? Now, by that happening, there's a couple of things we're looking for with that patient. We're looking for, first of all, neurodeficit. So remember our APPO scale? They'll start to decline. And then the second thing we're looking for is you'll have paralysis on one side of the body, where they'll be paralysed on one side of the body. Did everybody know this about stroke? Does anybody here know the anagram that we use to assess for stroke? Fast assessment, brilliant. Everybody know that? Fast, is it written in your books? Fast? Yeah, great. What does F stand for? Face, write that in. What does A stand for? Arms. What does S stand for? Speech. And then T? Time. Brilliant. So, with face, what are we looking for with the face? Facial review. Okay. So, let me ask you a question, because people fall into this trap quite commonly. First of all, what age group commonly suffer strokes? Young, middle-aged, or elderly? Elderly, absolutely. Look, something we've all looked forward to when we get on. Alright, one of those things, it's not picking on the elderly, it's just that's what it is, okay? As we get old, what happens to the elasticity of your skin? Reduces, and you start to sag. Can you see where I'm going with this? The amount of houses I've been in, and I've looked at a patient who's elderly, and I've been told, "Jeez, look at that droop," and they already look like drooping the dog. How am I going to know it's a stroke or not? I'm like, yeah, jeez, that's terrible, isn't it? No idea what's going on here, or whatever. Now, I listen to the family, because the family know the patient better than I do, but I can't see it. Okay? So don't fall into that trap. People think it's an obvious droop, because if their face is already drooped, how are we going to know? So what test should we do to assess the strength of their face?
Ask them to smile.
Ask them to smile, absolutely. That's why we ask them to smile. Now don't say, give us a smile, because most people just give you a bit of a grin. Ask them to smile and show you their teeth. It makes them do that goofy smile that pushes their whole face up. And you'll see one side going up and one side won't. Okay? Now, I was in a predicament before where I asked a lady in a fast assessment to smile and show me her teeth and shook them out of her handbag. I swear to God. True story. In a care home. Now, to be fair, she was absolutely wetting herself laughing. She thought this was hilarious. Now, what? Now, after we stopped laughing, like, we still have a job to do. So what we asked her to do then was puff out her cheeks, like that. Get them to do that, okay? Puff out their cheeks, and you'll see one side will go out and one side won't. Otherwise, you're going to ask them to stick their dentures back in. Alright, you only had your lunch as well, so. Ask them to puff out their cheeks. Now, that is a good definitive way to establish facial paralysis. Arms. One of the things I hate the most is all the videos I've seen, bar one if I'm honest with you. For arms, obviously the patient's going to be sitting because they're having a stroke. They tell you, put their arms out in front of them, close their eyes, and one arm should drop. If they're elderly and frail, that on a normal day is hard business for them, trust me. So, while they're sitting, put their hands on their knees, put your hands into their hands and tell them to squeeze your hands. You'll feel the weakness there already. Then get your hands, run them along their arms, up their elbows. Pick their elbows up and try and pull them out of the chair. But tell them to pull you back into the chair. And you'll feel it in the arms as well, because one will be strong and one will be completely floppy. Okay? That's how you assess somebody's arms definitively. Speech. What are we looking for with speech? I've never seen a slurred speech in the hundreds of patients I've brought to hospital. Not once. No, I'm not seeing a stutter either.
It doesn't make sense.
It doesn't make sense. Good on you. Neural deficit. They can't complete a sentence. They can't engage properly. They don't know what's going on. They're making what's called unaudible or inaudible sounds rather than actually speaking. That's what I've seen, I'd say 99.99% of my time dealing with patients with stroke. Okay? And then lastly is T for time. Two things with time. The first one is you need to find out what time definitively they were last seen normal. Okay? Because we need an onset time for the stroke. So the last time that they were seen normal. And then the second part of time is It's tickety tock. As soon as you cop a stroke, bring it in. Okay? Obviously get an ambulance on the way. If they meet certain criteria, as in age and no underlying conditions and certain things, and time frame, sometimes they're considered for a procedure that can basically reverse the effects of the stroke. But it's the big thing is about time with that. Okay? So you need to figure out time. How many indicators from FAS do you need to raise the stroke flag?
One.
Just one, absolutely. I have never seen a patient with one. 99.999% of all my patients I've seen have had all three. So you don't worry about it. But what if? If you're unsure, bring them in, bring it in, makes no odds, it's fine. Okay? But trust me, one marker is all you need. I've never seen just one marker. Okay? Because sometimes some are a little bit more difficult than others to pick up on. Okay? Has anyone ever heard of a mini stroke?
Yeah, it's like a TIA.
What do you mean fancy TIA? I like it. You know what TIA stands for?
No.
No? Oh, good on you, fair play to you. Yeah, mini stroke, TIA. TIA stands for a transient ischemic attack. Okay? Nice little fancy one for you. Just mini stroke. And what is a mini stroke? Very simply, the clot has gotten stuck. They look like they're having a stroke. Well, they are having a stroke. Pressure builds, and unlike other strokes where it'll rupture, it forces the clot on, so it then clears itself, and then you completely resolve of all stroke symptoms. Now, do you think they still need to go to hospital?
Yeah.
Absolutely. For every second that that's going on, there's no blood flow going past that blockage. Parts of the brain start to die. Okay? So absolutely. And some, they say as well, that it can be a sign of a bigger stroke on the way. So there are two reasons why they definitely still need to go to hospital, and then bring it in that way. If you suspect somebody's having a stroke, do you think you should tell them?
No.
Why? Panic the life out of them. Now, if it's a bleeding clot going on, that could be very bad news. But the other side of the coin is, let's say you went out to talk to the family. Yeah, I think Mary's having a stroke. Mary goes to the hospital, the family think, well, that's it, Mary's done, they'll good up, right? Let's be honest, all the others think that. They're going to the hospital, they're coming out in a box, they think it's a one-way system. But the family will think that, and they're like, oh, God, stroke. Because everyone knows a stroke doesn't mean a good thing. What happens if Mary goes to the hospital and has a thing called Bell's palsy? Have you ever heard that before?
Yeah.
Bell's palsy causes facial paralysis, and it's not a stroke. So, and then they have to come back to the care home, and the family produce it as a stroke. Is it your job to diagnose?
No.
Absolutely not. Whose job is it to diagnose? Doctors, absolutely. So don't fall into that trap. As much and as well your wishes may be, don't fall into that trap. What is it? Not really sure. Assessing for a stroke, but we don't really know. We're really to get help. That's it. Kick that with a touch. Alright? I don't even do an ambulance. I'll tell them this is what I'm assessing for, and I've picked up on something neurological, but I'm not really sure what it is. That's what I tell the family. Because after that then, whatever the diagnosis is, that's what comes from the doctors. Okay? So that's what we do with stroke and TIAs. Or mini stroke, okay? Fair play to it. So cardiac arrest, heart attack, stroke, and the last thing we cover then is choking. Choking is called FBAO, foreign body airway obstruction. Nice fancy word this. So, if you think about this logically, right, your airway is like a tube. It's going to either have what's called a partial blockage, a partial obstruction, or a full obstruction. If someone has a partial obstruction, they're still going to be because air is still going in and out because it's only partially blocked. If you come across someone that has a partial obstruction, what do you think you should encourage them to do? Cough it up, absolutely. Tell them to cough it up themselves. In a partial obstruction, tell them to cough it up themselves because the airway is not cut off. Alright? In a full obstruction, when that airway is completely blocked, what are you going to hear? Nothing. You'll hear nothing because there's no air coming up. Commonly you'll find as well, people are in what's called a universal choking position. You'll find people like that because they think they can claw out of the neck. Okay? And if it's in a public thoroughfare, 9 times out of 10 you won't be trying to do anything in a public area. You'll be finding these people in the toilet. Especially women, sorry girls. Last one I went was in a restaurant and she was scared, so she ran to the toilet. There you go. Now you're trying to resuscitate somebody in the toilet. One of those things. But if somebody has a full obstruction going on, there's no air coming up, trust me, the face is going to change colour real quick here. We do, first of all, 5 back slaps. Okay? So, in from the side, okay, good stable base for yourself and put your arm out. Bend your patient over, and in between the shoulder blades up to 5 times. Okay? Why do I say up to 5 times? Because you dislodge it until you keep digging in the back, and I've got thank you for it, alright? So up to 5 back slaps. If that doesn't work, we then move around and then do what's called abdominal thrusting. In a previous life it was called the Heimlich maneuver, now called abdominal thrusting. Put your hands around the stomach, find where the belly button is and where the base of the rib cage is, and go halfway up. Get your hand in here, get your other hand around here, and it's an in and up motion, because you're trying to get under the rib cage to force the diaphragm up, to force the lungs closed. And it's not nice and soft, it is bang, right in, trying to force air up the air, ready to get rid of it. Okay? Up to 5 times again, because if you dislodge it 1 or 2. It is very important to remember, start with back slaps first, and then abdo. Because abdo definitely has to go to hospital, because you literally mash up their insides. Okay? But remember, ABC, breathing before circulation. Okay? So, 5 back slaps, then 5 abdo thrusting, and keep going. 1 or 2 things will happen. You'll either dislodge what's going on, or they're going to go unresponsive. And if the patient is unresponsive and not breathing, what should you start straight away? CPR, absolutely. Now, in a previous slide we would have told you, do 30 compressions and then check the area of the mouth for whatever it is. Because typically when people choke the fluid or whatever it is up and down, and the airway will clamp around it to stop it going any further. So when they go unresponsive, it will relax. So when you're doing this, it'll definitely come up. However, nowadays, are you going to touch somebody's mouth or airway? So don't worry about it, you don't need putting air in anyway. So obviously, start with your compressions and keep tilting the head. If it's a family member, child, neighbour, whatever that stuff, fine. Have a look in the mouth after you've done the compressions and then scoop it out. And then, because you're going to be putting breaths into them anyway. If it is family member and you don't see anything in the mouth, try and put breaths in, but chances are you won't get them in because it's physically blocked. Okay? But keep doing it that way and prepare to resuscitate if obviously the blockage doesn't come clear. Now, AEGs, right, for adults, you know where your pad placement is here to here. For children it's front and back, and for infants it's also front and back. Okay? When it comes to this back slap